your cases for you and just let me know if you'd like me to scroll up or down. I do have both of your cases pulled up, so just let me know if you'd prefer to start with 1540 or 1561.
Okay, let me figure out who's who. Give me 1 second.
Sure.
I think this is the one I want to start with, but let me make sure.
Sure, absolutely. I also have the previously submitted one that goes along with 1561 in case you needed to refer back to that for you.
Okay, awesome. Thank you. Okay. So, gosh, I don't know why I'm nervous today, guys, but anyway.
You got it, Jennifer.
These two guys, one of them in particular makes me nervous, this guy here, because I just don't know him that well. So anyway, here we go. So this is a 57-year-old Caucasian male with Medicaid health insurance. And Mitra, if you can scroll down a little bit to the HPI, that'll be good. So he was referred to me by one of my colleagues who is kind of nice because she's really doing a good job at screening for Hep C, and she likes it that I'm treating. And so we have a good thing going there. She diagnosed him this year. And one interesting thing about this gentleman is that it's not entirely clear when he was infected. So you can see here that I put in the 80s, he had intravenous and intranasal drug use. He says he didn't share his works. At that, both in the 1980s and in 2012, he was incarcerated and got tattoos in jail. He had a blood transfusion after a motorcycle accident in 2013. He said that was a pretty bad wreck. He is married, has no known sex partner with hepatitis C or any risk factors. He's currently working as a mechanic. One interesting thing about his history is that he's quite a drinker. And as you can see from the physical, I saw him in the morning, and when I walked in the room, I could smell alcohol. He's drinking beer and a pint of liquor every day. He told me he can quit when I told him that, you know, it would be necessary for his treatment and better for his liver. He said he quit for 5 years after he had his accident, and he just said, I'll quit. And so I told him he needed to do it slowly. And I offered him Antabuse, which he declined, but he said he would cut down. He has not had hepatitis A or B vaccines. On his exam that day, his blood pressure was mildly elevated. He has, he's overweight, almost obese, with a BMI of 29. His liver was not palpable. He didn't have any jaundice. He did smell of alcohol. And then Mitra, if you could scroll down to his comorbidities. He is followed by my colleague for hypertension, GERD, hyperlipidemia. He had fatty liver on a recent ultrasound, and he smokes. His medications besides aspirin include a statin, Zyrtec, vitamin D he is on. I think I started him on that. Lisinopril, and metoprolol for blood pressure. And then he has a PPI, Omeprazole. He is not immune to hepatitis A. And at the end, I'll see if we start, I'm pretty sure we started him on vaccination, but we'll see. He has, interesting thing about this case is he has the isolated core antibody positive for Hep B. There are his vitals again, but we can go to the labs now, Mitra. I think his CBC looked pretty normal. That renal function, that creatinine was normal for our lab, I believe. I made notes at the end on anything that that was out of order. PT, INR results you can see there. The ALT, AST were mildly elevated, 51 and 52. Other liver enzymes were normal. His Apri was 1.0. His child Turco-Q class A and MELD score was 8. Yeah, his vitamin D was low, but he's on vitamin D supplement now. His AFP was normal. HIV is negative. He's a genotype 1A, and he his viral load was 6.8 million. And I have to pause here to thank Kaylee for helping me with basic math this week on a different case. We can talk about it some other time, but yeah, I was getting my millions mixed up. So his fibrosis stage is F1 to 2. I put in his cholesterol and LDL there because they're elevated. So let's see what I put additionally. Fibrosis score, to me, he feels complicated with that. You know, it's not a terrible fibrosis score. It's not 0. He obviously, the drinking is a huge problem for his liver health. And then that core antibody positivity is another big thing to talk about for me today. So I know the treatment options are Mavri, Epclusa, Harvoni, and Zepatir, but the things that I need guidance on are the potential to reactivate the Hep C, and I've forgotten how do I monitor for that, and does that affect my choice of medication? And then with the PPI, I know I'd have to alter the timing of his dose with Epclusa. And let's see, I had another question about, I think that, I think those medications are okay with the statin, but that was another thing that occurred to me, is do I need to do anything different with his statin, which his statin doesn't seem to be working anyway. And he was started on Hep A. He's on vitamin D, and the elastography, I think, is still pending. His liver ultrasound just showed fatty liver, I believe, but there is an elastography pending that was ordered by my colleague. So that's the deal. I just want to quickly look at that liver ultrasound to see just if there's anything else I need to say about that. It just said hepatomegaly, fatty infiltration. That was that. Slightly enlarged.
Awesome. Thank you so much, Jen. And I just wanted to say that I still get nervous just facilitating the session.
Okay,
So
good.
you're always so eloquent and do such a wonderful job. And I really applaud you all.
Very nice. I think I'm always nervous because I'm nervous there's something that I'm not seeing, but that's why I'm here at ECHO.
You're always so wonderful. Thank you so much for that. I'll open it up to the group. Are there any participants who have clarifying questions about the case or comments for Jen? Feel free to unmute or chat in. And any hub members with recommendations or feedback or questions or comments as well, feel free to unmute.
Hey, Jen, this is Kaylee. I want to tag along, and for some reason, I've been nervous all day today too. I don't know what's in the air. I was just texting Gilfus before I started or signed on, and was like, man, I've been like nauseous all day, and I'm super anxious, and I don't know why. So you're not alone, but it's yeah, I don't know what it is too. I think I get anxious when I have to present because I don't want to miss something or miss a teaching point or not explain something well. So I feel you on that, but you did an excellent job. And I always am so impressed whenever you present because you just really get such a great social history. You're so astute at picking up on cues like alcohol use. And I was looking at your other case and the patient was, you know, had admitted to you about his relapses. So, I mean, you're doing a wonderful job. I think, you know, you're really doing a service to these patients, and that's what ECHO's for, is so that, you know, you review these cases with us, and then, you know, we're all learning from them as we go through them. So don't, you know, I totally get the anxiety piece, but we're all here for you and to support you. So you know, don't ever feel like we're judging or anything like that, because it's never that way. We love
echo.
Yeah, we love the questions, and you know, I can even tell every time you present a case, like you even put down your whole thought process and then your questions, and that just really helps, because that means you're really learning and you're thinking through these. And so now, you know, I feel like we're just more of a support to you than really teaching. So you know, I want to point out, I kind of, as I was going through his case, you know, you did a good history in terms of his risk factors. You know, probably, even though he's got a pretty long exposure history or potential for exposure history, the blood transfusions is probably not as much as the risk factor, since he had them after 1992 when they started screening. But it's still good to get that information as well. To be honest, you know, being that he's had such a long time frame to where he could have potentially had this, plus he drinks so heavily, you know, and he's already almost 60, I'm very surprised that he doesn't have more advanced liver disease. So he's extremely fortunate to have gotten this far. As you hit the nail on the head, it's imperative he's got to stop drinking, or Hep C treatment's not really going to be of much benefit to him in the long run. I do want to point out, as far as your treatment options that you listed, you're correct. All 4 of those would be treatment options for genotype 1A. We tend to go with Mavyret and Epclusa just because they're covered by Medicaid. You don't have to do that additional baseline NS5A testing with the Zepatier, or if you were using Zepatier. Mavyret, you could do 8 weeks, Epclusa for 12. As far as the drug interactions, you brought up good points too. So his PPI would interact with either one of our Harvoni or Epclusa. You could either stop that if he's able to, or adjust the dosing, you know, administration times, and Rachel can touch on that more specifically. With the Mavyret, we also think about the statin. And so with Mavyret, rosuvastatin, we recommend they hold it. And with him, it seems like, you know, he has high cholesterol, but he doesn't have any history that I can tell of any cardiac events. So you may be able to just hold it for the duration of his Hep C treatment, since it's so short. But if there's any reason he needs to continue it, then if you're using Mavyret, would need to change it to rosuvastatin at no more than ideally 5 milligrams, but no more than 10 milligrams. With Epclusa, you could still use the atorvastatin at that dose, and that should be okay. But you know, again, ideally just hold it. You would need to watch for myopathies. In terms of the isolated Hep B core positivity and watching for reactivation, you know, and this gentleman, again, clinical signs and symptoms of acute hepatitis or flare. So, I mean, if he gets jaundiced, or he starts getting encephalopathic or abdominal distension, you know, any kind of clinical signs, the leg swelling, to be honest, if he's drinking that much, he may get jaundiced with drinking anyway. You know, it's kind of hard to tease out what it is. You'd really want to make sure you're monitoring his HBV DNA before starting him on treatment, just to see what his baseline viral load is, and then making sure to monitor his liver enzymes pretty closely while he's on treatment. So I tend to get them within a few weeks of starting treatment, and then follow them every 2 to 4 weeks while he's on. And if you see an influx or any signs of decompensation, certainly check your Hep B viral load again. Okay, and you can also check for Hep B surface antigen then as well. But you know, there's not any regimen that you shouldn't use or that's better than the other in terms of reactivity for Hep B. They're all black box warnings. Okay. The other thing I want to comment, and then I'll let somebody else speak because I know I'm talking a lot right now, but is, you know, his APRI was over 1. So in that instance, we get a little concerned. Yes, there's probably advanced liver fibrosis. His serum biomarker was more optimistic at a stage 1 to 2. And then even his liver imaging so far just shows some fatty liver. So if it showed nodular contour or any signs of portal hypertension, I'd be more inclined to say, yes, he has established cirrhosis. But I just really think at this point, we should treat him more cautiously because he has so many underlying risk factors. But it doesn't appear that he has cirrhosis yet. And if he does, it's well compensated. So you wouldn't have to necessarily worry about management from that standpoint. I think an elastography is still going to be useful since you have access to it, because it will actually give you an assessment of the stiffness of the liver. But I don't believe at this time you'd need to do ongoing hepatocellular surveillance screening on him unless the elastography shows an elevated value. Okay.
I meant to ask about that, Apri. Thank you. I forgot to put that in my notes. So that's helpful. Everything is helpful.
Yeah, I'll talk about that with our didactic today too. I'll go into those measurements a little bit more detail as well.
Thanks, Kaylee, a lot.
Sure.
Were there any other hub members who wanted to give some feedback or anything, Rachel?
Yeah, I'll piggyback. Kaylee kind of mentioned everything, and you, just like she said, you guys don't need me. You already identified all these things, but your sticklers are going to be the statin and then the PPI as well, depending on which one of the agents you choose. If you go with Mavorite, it's the problem there is the Lipitor. There's no recommended dose, so they recommend that you avoid those together. So if you're going to go with Mavorite, you could go ahead and hold that for that 8 weeks. That dose and the atorvastatin though is fine with the Epclusa. It just got to monitor for those myopathies, but there's no dose recommendation as far as changing it. So those would be your workarounds with the statin, depending on which agent you choose. And it looks like is that the correct dose of the omeprazole he's taken, that 40 milligrams?
Yes.
Okay. So with the Epclusa, that dose is too high. You'd have to reduce the dose to 20 milligrams for him per day. And the administration instructions to avoid the interaction is for him to take the Epclusa with food.
Okay.
And then take the omeprazole, the 20 milligrams, 4 hours later.
Okay. Okay, thank you.
Mm-hmm.
Good. Let's see. It wasn't. I really thought it was interesting that it's 31 years maybe since his exposure, and unless it was a tattoo in 2012 in jail or 2013, but I think I just thought it was interesting that he wasn't farther along in his fibrosis.
Hey, Jen, this is John. He's one to watch really carefully. If you talk about risk factors for fibrosis, sort of getting into an accelerated phase, he's got a lot of risk factors. He's male, he's older, he does other hits to his liver with alcohol, and probably has Hep B co-infection. Maybe it's active, maybe it's not. And I am always impressed with how articulate everybody else is, Rachel, Kaylee, and yourself. Remember the Hep B stuff? We emphasized it so much, but it was a rare occurrence. But he is, during the reactivation events, this was something that, happens rarely. I agree 100% with how Kaylee mentioned to monitor it, just keep an eye on liver enzymes and clinical and Hep B DNA. And he is precisely one of the fellows that it could be concerning in. I don't think we have a good handle on how much liver disease he may have, and would love to see that fibro scan too.
Yeah.
Yeah, get him treated. Good stuff.
Thank you. And just one clarifying question for you or Kaylee. So I would only get the Hep B surface antigen if I saw that his viral DNA was high.
No, I would get it in everybody.
Okay.
I would get a surface antibody, surface antigen, and a core on everybody. So we're calling him isolated core, but have we assessed his surface antigen?
Yeah, no, I got a surface antigen to begin with, and it was negative.
Oh, okay. Yeah. I mean, you can keep an eye on it.
Okay.
But the DNA and the liver enzymes will be kind of the key.
Okay. Awesome. Thank you. Okay, I think I don't have any other questions for you guys. Thank you so much.
Awesome. Thank you all so much. And
Oh, wait,
thanks, Jen.
I forgot one other thing. How old is he? You probably said this.
57.
50s? Yeah, so his age, if he does actually have evidence of active Hep B ever, so if he have DNA that's positive at all, or his surface antigen never turns positive, he would implicitly qualify for HCC screening. So
Okay.
remember, with Hep C, you'd have to progress through fibrosis and cirrhosis to get cancer. With hepatitis B, it has an oncogene, an X protein in there that can push you straight to cancer, even without going through scar tissue. And the screening advice for HCC and the second Hep B is very complicated, too complicated for me to tell you right now, because I don't remember it all. But it's dependent upon age, gender, ethnicity, as well as other fibrosis markers, etc. So there's a bunch of issues that go into it. But off the top of my head, I think if you're a Caucasian male greater than age 50, you would implicitly start screening him for HCC if he does have Hep B, true active Hep B, not old controlled cured Hep B. So and that's still in the differential you might have, and that's what the DNA and surface antigen following will help you differentiate.
Okay, good. Thank you. Okay.
Awesome. Jen, were there any other questions about this case before we go to your second case?
I don't, well, my only other one would be for Rachel. If he is struggling to quit drinking and wants antabuse, I think that's okay with everything else considered. Is that correct? As far as drug interactions? Oops.
Sorry, can you hear me?
Yeah, we can hear you.
I think I had two different things muted here. So yeah, I'm a newbie at this Zoom thing apparently. That would be fine.
All right. Yep, ready for next one. Mitra, thanks. I'm gonna pull up my next guy in my EHR in case there are questions I don't have answers to.
Absolutely. And I also have the other one too for the previous time that you presented on him. So just let me know if you want me to go refer back to that as well.
Okay, let's start with the one that I just did. This one is good. So this might have been my first ever echo presentation. And this guy, speaking of social history, since I presented, which was 2 years ago, I've now, a year ago, I started prescribing in our MAT program, and he's one of my patients there. And so I've really gotten to know him a lot, and he's a really interesting guy. So at any rate, he's a 41-year-old Caucasian male. He has Unicare Medicaid for his insurance. He, when I presented him in 2019, I submitted at that time for treatment, but that was back when, you know, Medicaid was not paying for a fibrosis score below 2 or lower, and he was F0. So since then, and also at the time, he was really struggling with his drug use. He is really much farther along in his sobriety now. He's still at a point where I'm not sure that we'll be able to get him treatment, but he, for the past 7 months, has been, after having done 3 rounds of rehab, inpatient rehab for heroin and meth addiction, he's now had 7 months of sobriety minus about 6 relapses. And that's how I say it to him, because I just think we all see that he has come such a long way. He's really motivated to keep working on his sobriety. And the Hep C treatment is part of what he's kind of keeping his eyes on the prize with, because it motivates him to not use. Now, I will say when I'm talking about his sobriety, I'm not including alcohol. So he also drinks, beer, and rarely he drinks vodka. He's done really pretty well with that, cutting that out, but he's probably had more than 6 relapses on that. He recognizes that the alcohol leads him to use the other drugs, and so he's trying to put it all together. He's just a really interesting guy, and he's just working so hard that I love working with him. At any rate, back to his Hep C, his comorbidities include hypertension, constipation, which may be related to his Suboxone treatment, but it may also be related to his diet. He says all he eats is cereal. Depression, which he sees a psychiatrist for, BPH, and GERD. His medications, he's currently on amitriptyline. We may change that soon to nortriptyline to see if that gives him any improvement in his constipation. He's on amlodipine. I forget what that next drug is. I think that's is that Seroquel? I think that's an antipsychotic, probably for depression. Cymbalta, Remeron. Is it on a PPI? I don't see it. Let's see. Let's scroll down. Yeah, there it is. Pantoprazole, Miralax for his constipation, and his BPH medication. His Suboxone there is listed as well. He is not immune to hepatitis A. We started him on vaccine quite recently. He is immune to hepatitis B, and you can see his, he has core and surface antibody positivity, negative surface antigen. Those labs were from 2020. He is, has a BMI of 24. I just keep thinking about things this guy has said, and I want to digress and tell you guys about, but I won't go there. He's just a real character. We all just are really proud of him for his work and his recovery. His CBC, there you can see it looks normal, including platelets. His kidney function is normal. PTINR look good. His AST was quite elevated in 22. The day we drew labs. These labs were actually, this CMP was actually from the fall, and I need to repeat all that. I apologize that this is old. Bilirubin is normal, protein normal. His Apri 0.7, child Turco-Q class A, and his MELD score is 6. His iron studies were normal. His vitamin D was just barely in normal range, but I believe I've started him on vitamin D to try to boost that up. AFP 6.3, can that be right? That doesn't seem like that can be right. Let me double check that. Yeah, I guess that's right. I don't know why that looked high to me, but that's normal. He is HIV negative, non-reactive. He is also a genotype 1A with a viral load of 5.6 million. And his recent fibrosis score had gone from an F0 to an F0 to 1, which I actually used to try to motivate him to tell him that he had gotten slightly worse, which is true. To try to get him to emphasize to him that quitting drinking really now is, he needs to double down on that. He's trying, but he doesn't do as well with that as he does with his other substances. And his GGT was high, as you can see there. And then that necroinflammatory score, I think, was high. And I calculated the Fib4. Now I can't remember if what that means, to be honest with you. But there it is, 3.89. So we can talk about that. Oh yeah, so I wrote this down. So I was curious. Yeah, so the Fib4 calculation, I think, gave him a higher fibrosis score than the FibroSure. He has an ultrasound pending, and I could also get elastography if you think that's necessary. He has a little, or important, he has a little bit of trouble with transportation. At the time we talked previously, we talked about Harvoni. I think at this point it may be that Epclusa and Mevrit are what Medicaid would prefer. And as we talked with the previous case, I would adjust the PPI dosing if we went with Epclusa. When I prepared the case, it's interesting that I asked about the Apri on this one and not in the other one, but that might have just been because filling out the case forms, there's a lot to keep track of. So we could talk about that again. I've started him on Hep A. So I will start him on vitamin D. I don't have all the iron studies, but his ferritin was there. And then I said elastography is pending. Maybe I ordered elastography instead of ultrasound. I'll check on that. And that's, so that's, I guess, pretty much him. I'm not sure if I asked a clear question there, but that's the story.
Well, that's awesome. Thank you so much, Jennifer.
Oh yeah, I ordered elastography. Good.
Nice. And I can also pull up the case form again if you anyone needs to refer back to some labs or some of the questions and stuff there. But anyone with comments or thoughts they wanted to share with the group, feel free to unmute.
Hey, Rachel, this is John. This guy's a Medicaid patient. Will he be able to, without the sobriety period, will he even qualify?
No, because they require the 6-month minimum, and the patient has to attest to it as well as Jen. She'll have to attest to it too. So he'll have to be clean for 6 months first.
So Jen, he's got some spare cash sitting around that he can buy meth and beer with. Maybe he could buy it abroad. That's an option.
Interesting point. He and I talk all the time about, and actually it's so sad. He gets to 90 days and then he uses. I mean, he really is sort of self-sabotaging. So now and he keeps saying that the prospect of getting treatment at 90 days is what is helping him to stay sober. But so I thought it was 90 days, but it's actually 6 months, Rachel.
No, you're right. I always do that. It transpose them. It is 3 months. You're right.
Okay. But still, I have to testify that he hasn't used and that he's not abusing alcohol. And so far I haven't been able to do that. So he's well aware of that, as am I.
Well, yeah, throw it out there as an option. I mean, maybe he's got a spare $600 or whatever to buy it. I mean, it would probably work. And this is a guy having multiple hits to his liver, and clearly his AST, ALT look like he's drinking, and that's the major insult. I think his Apri, Kaylee's going to talk about this probably next hour, but there's limitations to all that stuff. But I think the Apri is falsely pessimistic, both of them, because they're so dependent upon the AST. But clearly he's somebody who could advance to chronic, or it should say get to advanced liver disease quickly with all the insults he's doing to it. It'd be great to treat him. I don't think they're going to have any public payer be willing to do that. Maybe he'd willing to buy it.
Hey, Jen, this is Kaylee. I'll just tag along on that as well. Since this is a guy that you have a really good rapport with, and he seems like he's motivated with his sobriety, dependent on whether or not his Hep C is treated. I may, even though he probably could get treated if he just, paid for it out of pocket and got the generic overseas, but then I'd worry, is he gonna kind of lose his motivation to stay engaged with you? So I certainly wouldn't withhold that information from him, but I would just be open about it that, we have an alternative option, but really the long-term goal is for him to maintain his sobriety and his liver health. So he doesn't seem to have advanced fibrosis yet. So you do have some of that time to allow him to maintain a period of longer sobriety before treating his Hep C. the big thing, again, like Dr. Gilfus said, is alcohol is really taking a toll on him. I mean, his AST, it's twice, it's a 2-to-1 ratio over that than what his ALT value is. And so that's more indicative, that pattern, just that this is more alcohol related inflammation, and certainly influences that APRI calculation and FIB4 calculation being higher. So those are probably not accurate markers. The other thing that you mentioned was his necroinflammatory score on his fibro test, that was also high. Again, I also think that's a lot from the alcohol use as well. So I would really, maybe even make an agreement with him that if he can cut out the alcohol, even in the setting of, sometimes some relapses with the meth addictions, just like any other chronic condition, sometimes people fall off the wagon. He's motivated, he's engaged. So I would use more of the stopping alcohol than his slip ups every once in a while, with the drug use as a driver for getting his Hep C treated, and make sure, of course, you're talking with him about ways to kind of, when he does relapse, how to be more responsible so he avoids infections and other complications of his drug use. But especially stimulants like meth, we do see a fair amount of transaminitis just from those stimulants as well. So just kind of let that all play into it. It's really the other things that you're doing that's going to cause you problems, not really necessarily just the Hep C.
Okay, very helpful. Thank you. This is where the direction I have started to go with him, so that will help reinforce what I've told him.
I think it's great that he's so open with you. I mean, I think sometimes, when we hear relapse, and this is more so, you do MAT. And so I think that's just so fortunate, because you really know your patients. Whereas, when we hear relapse, my thing is, okay, crap, like, they didn't fail. This is just part of this dynamic process that they're going through. And so it really stinks when somebody slips up and now you say, okay, now we have to start the clock back over again. And so this is somebody that's really engaged with you. And so I would really use that as the impetus, but he's got to stop the alcohol and, the meth, to be honest. I as much as I wouldn't want him to keep doing it, I mean, I think that's something that's not as much of a problem for him at this point. He's at least actively working with you and psychiatry on that.
Yeah, good. Okay, thanks. And it's, like I pointed out, it's been 6 months, so I can repeat those labs too. And
yeah. Oh, and one thing I would mention, I know you said you had an elastography pending on him, but since he's somebody that you may not be treating right away,
yeah.
When you're deferring treatment, I would still at least do like an annual fibrosis assessment on him.
Okay.
So how you said, he'd advanced a stage, that degree of progression can be variable once that fibrosis is established. So I'd still, he's pretty young, but I'd still monitor him, really, since you're not treating his Hep C quite yet and he's still drinking, I'd still do follow-up imaging on him, whether it be elastography and ultrasound, about every year.
Yeah.
If not a little bit more frequently if his liver enzymes keep going up.
Okay, good. I'm hoping, I mean, it's probably unrealistic, but I'm just hoping against hope that he'll, make it. We thought this guy was going to die a year ago. So he's come such a long way, and I'm still rooting for him. Thanks, you guys.
Thank you so much, Jennifer. Before we move to the didactic portion, Jen, were there any other comments or questions you wanted to have addressed about both the cases?
Nope, that's it. Thanks, guys.
Sure.
I have
Dr.
a
Polly?
question. I mean, now when we say that they should be 3 months free from alcohol and drug use, are they strict about marijuana also?
There's actually an exclusion for marijuana, so that's okay.
Okay.
Yeah, so they don't have to be clean from that. And then the alcohol, the verbiage they have in there is that they can't be abusing alcohol. So you don't have to be strict, no alcohol. They could, socially drink within moderation.
Thank you.
Alrighty, thank you all so much for the feedback, comments, and questions. And as always, thank you, Jennifer, for the awesome case presentations. All right, Kaylee, I'll pull up your didactic for you and just let me know when you'd like me to go to the next slide. I'll turn things over to you now. Thank you.
Awesome. Thanks so much, Mitra. So I think that Jen's case has kind of had a good segue, at least in terms of the fibrosis for our didactic today. And so I'm going to be talking about why genotype and fibrosis matter. Next slide. So we've seen coronavirus a lot lately, and I just wanted to kind of revisit what the hepatitis C virus looks like at the micro level. So, I can try to explain it to you based on this visual, but basically it's a single-stranded positive RNA virus, and it's comprised of the envelope glycoproteins, which are attached, those little, those little things sticking out on the lipid bilayer. That encompasses the viral core protein or the capsid protein, and then inside of that capsid protein is the RNA. So the HCV genome, it's approximately 9,500 nucleotides. It has an extremely rapid replication cycle. So billions of new HCV virions are produced daily. And so because it's such a rapid replication cycle, one of the kind of fortunate things for that is that the polymerase enzyme of RNA viruses like HIV, they really lack proofreading ability. So there's lots of opportunity for replication errors to occur. And on average, per replication cycle, we really see 1 to 3 errors. Many times those errors result in like a lethal mutant. So either it renders that genome for that virion non-functional, or the replication, the virus is incompetent in terms of it's unable to replicate further. So in some instances, however, some of these errors or mutations, they persist, and then they account for the tremendous viral heterogeneity that we see with hepatitis C infection. Next slide. So what's the genotype then? Really just the genotype is the expression of the viral heterogeneity that plays a role in the diagnosis of HCV infection, the pathogenesis of disease, and the treatment response. Over time, the degree of this Hep C diversity has evolved into 6 major genotypes and numerous subtypes. And so that's really also led to a distinct geographic distribution of these HCV genotypes. Next slide. So on this slide, I just wanted to kind of touch base. We tend to talk about how genotype 1 is the most common in the United States. I don't know how clearly you can see the labels beside the color markings, but the red signifies genotype 1. And so this is most prevalent globally, not just within the US. Genotypes 2 and 3 in the US are still less common, but they still comprise up to 30% of genotypes in West Virginia. And then in the US, 4, 5, and 6 are pretty rare to see. So although genotype 1 and then to a lesser degree 3, we see those more prevalent than all genotypes globally, we do see, some kind of specific distribution throughout the world. So for instance, blue, the little blue coloring, there's a higher prevalence of genotype 2, and that's in West Africa and then some small parts of South America. Genotype 3 is the green highlight, and that seems to be more prevalent in South Asia and then parts of Scandinavia. Genotype 4, which is the yellow, really is consolidated to the Middle East, Central Africa, and Egypt. And then genotype 5, if you can even find it, it's way down at the south of Southern Africa, but that's really makes up of less than 1% of global cases. And it's really almost exclusive to Southern and Eastern Sub-Saharan Africa. Genotype 6, that little purple area that you can see, if you can see it in South, is more exclusive to Southeast Asia. And then we don't really talk about genotype 7 because there's only a handful of cases that have really been identified, but that tends to be confined to Congo. So we can see, Hep C genotype is important from an epidemiological standpoint. Next slide. All right. So we also know, genotype 3 is associated with relatively faster rates of fibrosis progression, higher prevalence of severe steatosis, and a higher incidence of hepatocellular carcinoma. So when we talk about, we kind of worry about genotype 3, that's the one to pay attention to. This is the why. The determination of HCV genotype also helps guide our Hep C elimination strategies. So not just in terms of treatment regimens like dosing and duration of therapy, sometimes adding ribavirin, but it explains why the interferon response during the interferon era was really subpar, because interferon doesn't target the virus itself, it really amplifies the patient's immune system. And because this is such a quickly, fast, rapid replicating virus, and there's so much variation, it's really hard for our immune systems to recognize and successfully eliminate these HCV infected cells. So another strategy to point out is, we kind of say that it's difficult. That also makes it difficult for conventional vaccine development. But really, if you think about it, vaccine development in countries where diversity is constrained, they may have a better kind of more strategic opportunity for vaccine development in places like, for instance, Egypt, where really you predominantly are only seeing genotype 4. So if you have kind of more diverse heterogeneity within an area, it's going to be really hard to get a vaccine that's going to work. But if you really have consolidated genotypes or not very diverse genotypes in certain areas, then Hep C vaccination actually could be realistic. So next slide. All right. So I'll talk about direct acting antivirals, because obviously this is our target now for hepatitis C virus. So whereas interferon didn't target the virus itself, but rather amplified your immune system, our direct acting antivirals are exactly what they say. They directly act on the Hep C virus. And so they really suppress ongoing replication by targeting essential proteins of the Hep C virus. These proteins, they work the same regardless of genotype, but they might be a little bit structurally different due to some small mutations. However, since these proteins are essential for the HCV life cycle, the structure of their active sites are really less likely to change due to random mutations. And so therefore they really remain relatively consistent between different genotypes. With this slide, I just like to include it because we always throw out, Mavyret, Epclusa, Harvoni. But really, when we're talking about these agents, we're really talking about at least two different direct acting antivirals that have at least two target sites, and those are in a combination pill, and that's what we refer to as the brand name. And so really the three classes that we see are NS5A inhibitors, NS5B inhibitors, and NS3 and 4 protease inhibitors. The quick and easy way to remember these, so when you're talking about Mavyret or Zepatier or Epclusa, is with the combination of drugs, if you're looking at the generic, Ledipasvir and Elbasvir, if they have the A in them, they're an NS5A inhibitor. Sofosbuvir is right now really the only recommended NS5B inhibitor that we use, so that's pretty easy to remember. NS5B would be a Sofosbuvir, and then our protease inhibitors, those names contain a PR, so protease and PR. So that's just a quick kind of way to remember each class and the medications it's comprised of. Next slide. So these are the big four that we see. Harvoni, which tends to treat genotypes 1, 4, 5, and 6, is basically Sofosbuvir and Ledipasvir. So it's an NS5B and an NS5A inhibitor. And I'm doing these in order of when they kind of came out, okay? Zepatier treats genotypes 1 and 4. Elbasvir is the NS5A, and then Grizopravir is the protease inhibitor. And then we have our two pan-genotypics that we're so fond of and often referred to, and those are Epclusa and Mavyret. They treat genotypes 1 through 6. Epclusa is Sofosbuvir, or NS5B inhibitor, and Valpatisvir is our NS5A. Mavyret is glisapravir, which is our protease, and then pibrentasvir is the NS5A inhibitor. So basically these combination drugs, it's typically an NS5A inhibitor plus either the NS5B or the protease inhibitor. With Vosevi, which is our only salvage regimen, it actually takes one drug from each of these classes. So it's actually an NS5B, NS5A, and a protease all combined into one pill. So really, these are acting on at least 2 different target sites to disrupt the replication process. And this has really resulted in over 95% cure rates, regardless of the genotype. And so if you think about it, back in the early 90s, when alpha interferon was introduced, the first rounds, it was less than 10% virologic response rate. And then by the time, then they kind of extended the course of interferon therapy, the duration, added ribavirin, introduced the first generation protease inhibitors in 2011. And by that time, the response rate had increased to over 70%. So now with these newer generation drugs that are interferon sparing, we really are seeing, greater than 95% cure, which is great. All right, next slide, please. I just want to point out 2 trials real quick, because just really about our 2 pan-genotypic agents. So this first slide is the brand name Epclusa, but it's the data from the Astral 1 and Astral 3 trials. And this is across all 6 genotypes. I don't want you to really worry about, interpreting it, because I don't want to spend too much time on that. But it really includes treatment naive and treatment experienced patients with and without cirrhosis. SVR rates across the board. So each of those orange bars is dependent on genotype 1A, 1B, 2, 4, 5, and 6. 97 to 100% cure rates using this agent. With genotype 3, 97% cure rates, and these are with patients that did not have cirrhosis. And again, point out, really with genotypes 2 and 4, there was 100% efficacy. Next slide. With Mavyret, which is the glisapravir pibrentasvir, I can't even talk right now, for 8 weeks in patients without cirrhosis, again, across the board, genotypes 1, 2, 4, 5, and 6. Really, to us, this is important because we don't really treat genotype 4, which had a little bit lower response rate. But for 1, 2, 5, and 6, it's over 98% response. With genotype 3, this was only looking at non-cirrhotics, but it was an overall 95% response rate. Okay, next slide. So now that we're in an era where pan-genotypic agents are available, is it really important anymore to still genotype or subtype because we have such great response rates? Next slide. I don't know. Let's keep talking. We'll figure it out. So I'm going to take a step back from talking about genotypes and bring in the concept of, why we talk about liver fibrosis, and really want you guys to make a good assessment of liver fibrosis. So really, this terminology, I want you to remember that fibrosis is a dynamic process. So when we talk about is somebody cirrhotic or not, certainly we want you to establish that first, and then whether they're decompensated or compensated if they are cirrhotic. But just remember, this is really something that's ever changing. It's not just linear progression. Once the insulting factors are removed, there's a lot of opportunity for that fibrosis to improve or regress. And I kind of say it's like the liver's like the Wolverine of organs, so it can regenerate if you just give it some time and let it happen. So, but really, liver fibrosis, it's the excessive accumulation of the extracellular matrix proteins, including collagen, that occurs in most type of chronic liver diseases. It can result certainly in cirrhosis, as we talk about, portal hypertension, liver failure, death, may ultimately require liver transplantation. Next slide. All right, so then these are just the stages. I just like this picture because it kind of gives you that visual, and I really like visuals. But so stage 0 is not on here because that's a healthy liver. Stage 1 is really when you're just seeing some liver inflammation. Once stage 2 is developed, we see limited accumulation of scar tissue, or fibrosis, but still preserve liver function. By the time we get to the more advanced stages, stage 3, you really start seeing extensive fibrosis and scarring, but you're still having relatively normal functioning. So we call this bridging fibrosis. And then by stage 4, this is really when we start worrying about a cirrhotic liver. So really substantial scarring, and then there's some impairment to the liver's vital functions. Next slide. All right. So with hepatitis C, because again, liver disease, obviously it's can be caused by several things, but we're really focusing on this talk about Hep C. And so there's some variability in terms of how liver disease progression occurs dependent on the etiology. With HCV progression, this is something that really occurs over decades. It's not something that happens right away. And, about 55 to 85% of patients that have Hep C develop chronic Hep C. And of those, that group, only about 20 to 30% actually ever develop cirrhosis. And that's going to be over a period of 20 to 25 years. It's not something that will happen right away. So pretty small proportion, but still significant. And then, 25 to 30 years, once that cirrhosis is established, if it's not managed, that's when we start seeing decompensation. So hepatocellular carcinoma occurs at 1 to 4% per year, end stage liver disease 2 to 5% per year, and then death. So this timeline, it's really, again, over a long period. It's not quickly. Next slide. All right. Dr. Gilfus mentioned these today, or at least, a few of these today, but these are also some additional factors that are associated with hepatitis C liver fibrosis progression. So kind of think about this when you're assessing your patients. Someone that has only Hep C that we're worried about, we wouldn't really expect to see liver disease progression happen quickly. But when you start taking into consideration some of these additional factors, that's when you start wanting to, make sure you're monitoring those patients more closely. The non-modifiable host factors, certainly the baseline fibrosis stage and inflammation grade. If a patient is older at the time they're infected with hepatitis C, it's been associated with faster liver fibrosis progression. Male sex, organ transplants or immunosuppressants with a solid organ transplant. Some of the modifiable factors, certainly alcohol, NAFLD, obesity, insulin resistance. Also, we tend to see, with iron overload. And then some studies have also showed an association with disease progression in terms of even tobacco use or marijuana use. As far as the viral factors, genotype 3, as we touched on, has that capability to progress liver disease at a fast rate, as well as co-infection with HIV or hepatitis B. All right, next slide. So take-home point is fibrosis assessment is essential for all of our Hep C patients. The morbidity of Hep C is almost completely related to the development of cirrhosis. The presence of cirrhosis might affect your treatment regimen, the duration, and or the use of ribavirin. Advanced fibrosis, stage 3 or 4, warrants long-term liver disease management, such as our hepatocellular carcinoma surveillance screenings. We do this via imaging every 6 months, plus or minus an alpha fetoprotein. And then if a patient has an elastography value greater than 20 and a platelet count less than 150, or any clinical signs or symptoms of decompensation or varices, then we would do a screening EGD for esophageal varices. And really the kind of criteria change here is, really limiting it to those that have a higher degree of liver stiffness, and thrombocytopenia really comes from those that don't meet that criteria tend to have a much lower threshold for esophageal varice bleeding. So it's not as urgent to get the EGD. Next slide. And this is the one I wanted to touch on or spend, kind of a little bit of extra time on, because, we were talking about this today, but modalities we use to assess fibrosis. Certainly we have our Apri and our Fib4. You can download a app or a calculator, a medical calculator, to just pull up and plug in the numbers for these two equations. But these are just a really quick assessment using only a CBC in your hepatic panel. So most time you're already going to have this on your patients anyway. The APRI is really just the AST patient's value divided by the upper limit of normal of the AST, and then that total value divided by the platelet count, and then you multiply it by 100. So the Fib4 also factors in the ALT and age in addition to AST and platelets. The thing about these is they have a very good negative predictive value. With the Apri, there's also a high specificity for cirrhosis if you have a value greater than 2. But once you get to that value, the sensitivity is much lower, so it's less than 50%. We usually use thresholds of greater than 0.7 or 1. That's about a 70% sensitivity and specificity for cirrhosis. So again, these calculations aren't great, but they're pretty quick to do, and so that's why we tend to go to those first. With a Fib4, less than 1.45 is really a 95% negative predictive value for advanced fibrosis. More than 3.25 has an 82% positive predictive value for advanced fibrosis. So I think with Jen's case, she had some discrepant measurements. And again, just remember, none of these calculations are perfect. And so really you're trying to make your judgment on how much liver disease is underlying based on that probability, taking into those considerations of the factors for liver disease progression. With a fibro test, now, typically when you order this, it's gonna put the report back with a numerical value and then the interpretation based on the fibrosis stage, and it ranks at 0 to 4 using the Medivir score. It's really taking 6 different parameters, plugging it into an algorithm, and it's assessing the fibrosis as well as the necroinflammatory activity. So with this one, greater than 0.74 is suggestive or more specifics, about 85% of stage 4 cirrhosis. But the reliability of this test can really be influenced by several things. So it could be influenced by really any acute inflammatory state. So you're not going to want to check this when a patient's inpatient. So if they have acute hepatitis, any kind of acute inflammation, extrahepatic cholestasis, acute hemolysis, you're not going to want to check this because it's going to give you an overestimate. Also, if you have a really high fibro test, look at the individual parameters. They're usually listed at the bottom of the report. If you have any isolated extreme values, that should really lead to caution in you interpreting the result as well. So if your Fib4 or ABRI are really, saying, hey, there's no fibrosis, and then the imaging looks great, and then the fibro test says F4, it's probably because of the reliability. It's probably just not accurate in that patient. With our imaging modalities, this assesses your liver contour as well as lesions. So in anybody that I'm worried about cirrhosis, I automatically do imaging on them. I'm not going to fool around with ordering these other tests and only using those, because you want to do a good job of making sure that there's not an underlying cancer, and also assessing stability. So if you see any hepatic nodularity or evidence of portal hypertension on your imaging, that's really 95% specific that you have severe fibrosis or cirrhosis. Okay, so good to rule it in. Also, if there's no abnormal finding, it's fairly good at ruling it out, but it's hard to assess those in between stages. The liver elastography, and you can go to the next slide. That's just your regular ultrasound, but it also has an additional kind of programming mechanism that assesses your liver stiffness as well, that's measured in kilopascals. This is much more widely accessible now. For a long time, we only had like 2 elastography machines in the state of West Virginia, but usually your local GI provider is probably going to have access to this test. And so I put on here because they're, again, varying kind of liver disease causes, you would assess these values differently. I highlighted chronic Hep C in red. We really use a threshold of anything greater than 12.5 kilopascals. We're more confident that there's underlying liver cirrhosis. There's a high sensitivity, so 87% using that threshold as well. Influences of this test. So if you have an obese patient, if they ate right before the test, there's a lot of liver inflammation, a high ALT, those could really influence this exam as well and give it a higher score. So if you have an elastography of 19 and then the imaging findings say smooth contour, no abnormal findings, you may want to think, rethink if there's something else influencing that score. And I think I just have a couple more slides because I know I'm running behind. Maybe next slide. Let's see. I'll go through 2 more slides and then I'll stop. So if the patient has established or probable cirrhosis, again, you want to make sure you're determining if there's any signs or symptoms of decompensation. Once you've established cirrhosis, then you can calculate your child's Pew and your MELD scores. Remember, these help determine the prognosis of a cirrhotic patient. So we don't necessarily need to check these in everybody with Hep C, only if there's that established advanced fibrosis. These also help guide when to refer to a liver transplant center. So for echo, we'll treat child's Pew class A. If there's a MELD of 15 or 16, you might want to refer to a transplant center first. Now, a lot of times they won't consider transplant unless there's a MELD greater than 18 or 20, but you certainly want to get them at least evaluated by a transplant center. Next slide, and then I'll stop. So other important points in decompensated cirrhosis, make sure you're really careful with these patients, let them know what signs and symptoms to monitor for. Really, you can decompensate at any time. And so they really need to be astute at letting you know or and understanding what symptoms to watch for. Again, jaundice, abdominal distension, pain, losing or gaining a lot of weight in a short amount of time, bleeding, like confusion, which I feel like I'm having now, leg swelling, and certainly have a low threshold for referring them to hepatology or a transplant center. Also understand that we tend to not treat Hep C patients, at least in echo and even in ID. All protease inhibitors are contraindicated as those can progress liver damage or liver disease faster. But even our protease sparing regimens can also cause liver injury in this setting. So really not safe for us to treat anyway. As far as treatment, the hepatologist will typically add ribavirin or extend the duration of therapy. And the other thing too is just with decompensation, the main goal, remember, is to really control those signs and symptoms of decompensation in conjunction with your hepatologist. If you can get their MELD stabilized enough, then you can attempt to treat their hepatitis C, because again, this is a dynamic process, but just be cautious to avoid this concept of MELD purgatory. So if a patient's got a MELD of more than 18 or a child's Turcotte, C, you might treat their Hep C and lower their MELD, slightly, but it's not going to be enough to save them a transplant, and it actually may hurt them because it's going to lower their priority on the transplant list. So you don't want to keep them miserable, treat their Hep C, and then have them wait longer. And I'll stop there because I think I had too much. So we'll stop there today.
Thank you so much, Kaylee. That was really wonderful. And as usual, we'll attach the PowerPoint in the recap email so everyone has a copy of those. Did anyone have any questions or comments for Kaylee?
Just thank you. That was great.
I agree. And we're getting a lot
amazing.
of.
Good job.
Remind me to talk to you guys about resistance testing at some point, because I wanted to bring that up too, but I don't want to rush through that today.
Absolutely. That sounds great. Thank you so much, Kaylee. All right, if anyone has questions for Kaylee after the fact, feel free to email them to me and I can send them her way. But the only announcement I have today is our next session will be on March 25th, and Angela Walczyk will be presenting on medication regimen. So keep an eye out for that reminder. Thank you again, Jennifer, for the cases, and thank you, Kaylee, for that great didactic. We'll see you guys next time.
Thank you, guys.
Thank you.
Thank you.